Bournemouth University and Time to Change logos are shown on screen, followed by the text. Understanding Schizophrenia, Dr. Laurence Mynors-Wallis, Consultant Psychiatrist and Medical Director, Dorset Healthcare University NHS Foundation Trust, Registrar Royal College of Psychiatrists. Then the text, this video is part of the Equality and Diversity outreach work being undertaken at BU. The video screen shows the logos Bournemouth University, Dorset Healthcare University NHS Foundation Trust, Dorset Mental Health Forum, boroughpool.com and the Richmond Fellowship, and is laid out with a picture of Laurence on the right hand side with the title Mental Health Awareness Week 2014. On the left is the area where the slides are shown. Slide 1 reads, Schizophrenia, Professor Laurence Mynors-Wallis, Medical Director and Consultant Psychiatrist, Bournemouth University, 8th of September 2014.
I'm Laurence Mynors-Wallis. I'm a consultant psychiatrist in Poole, and that's the main part of my work. I'm also, as James said, Medical Director, which is a management role within the main mental health trust, or the only mental health trust in Dorset, which is Dorset Healthcare. But my day job, and I've been a consultant now for about 20 years, is looking after patients in Poole, in the community. And I look after a mixture of patients with other members of the team. And the talk today being on schizophrenia, I should imagine probably about 1 in 5 of the patients I look after have schizophrenia. So not the majority. The majority of patients I see have depression and anxiety, severe depression and anxiety type symptoms, but about 1 in 5 of the patients that I look after have schizophrenia. If when I'm going through the talk there's something that you absolutely want to stop me on and say, well, that's rubbish and I disagree with that and it's outrageous, you can stop me, but probably otherwise there'll be plenty of time for questions at the end, and I'm happy to take any questions on schizophrenia and more broadly. As James said, in fact, it is very good news, the announcement today about increased resources for mental health. Mental health is always been the poor relation of physical health. It's estimated that about 22-23% of the morbidity, that is the disability caused by health-related problems, 22-23% of all disability caused by health problems, caused by mental health problems. So nearly a quarter of people who struggle because of mental health problems. But the amount of money that's spent on the NHS is about 11%. So that is clearly disproportionate. Mental health has always been the poor relation, and the positive news coming out of the Lib Dems, and it's a pity that it's unlikely they're going to get back into government, isn't it? But the good news is very much a focus on, even within mental health, the poor relation in mental health has been children's mental health. And with schizophrenia, as with many other conditions, if you can get in early, you can actually make a more of a difference than if you've got in late, and actually putting more resources into that's going to be enormously helpful. So,
the slide changes and the 6 points are read by the speaker.
What I'm going to, is I don't want to give you a lecture on schizophrenia, but there's lots of myths about schizophrenia. Schizophrenia is seen as quite a frightening condition by the general public. It actually doesn't get a very good press. Almost the only time schizophrenia gets mentioned is in the context of some dreadful event, a homicide or a suicide. And I'll come to how fair that is later. But I just thought we would, I'm structuring the talk around these thoughts about schizophrenia. Actually, what is it? How common is it? How do we treat it? Is it just about mental health problems? And coming to the end of people with schizophrenia are dangerous. And within that, hopefully you'll get an understanding of what the disorder is.
Slide changes with the text, Schizophrenia means split personality.
And actually, this is probably the most common perception of what schizophrenia is, that it's split personality. And it's just complete nonsense. It isn't split personality. It has nothing to do with Jekyll and Hyde. Interesting to know where that has even come from. But schizophrenia is absolutely not. So if you just take one thing away from today, well, there's 2 things. I'll come to the one at the end, and that's about how dangerous patients with schizophrenia are. It isn't about split personality.
Slide changes and shows a drawing of a person with 2 heads. 2 speech bubbles say, I'm a schizophrenic, and the other one says, and so am I. Slide changes and shows 3 boxes with the titles positive symptoms, negative symptoms, cognitive defects. All the bullet points are read out by the speaker.
It's a condition which has a variety of symptoms. Just like other conditions have symptoms, just as if you have diabetes. What is diabetes? Diabetes is are people that have they have low sugar when they feel faint and dizzy. They have high sugar in which they drink lots, and at worst they can go into a coma. It causes problems with various disorders, with your eyesight and your kidneys and all sorts of, and your heart. The advantage of diabetes is that there's a test for it, and that's the difference with schizophrenia. Schizophrenia has symptoms like other disorders, but actually, as I'll come to in a moment, that there isn't a test. But the symptoms are these. We divide them into positive, negative, and cognitive. Now, I'll just give a bit of an explanation of those. The positive symptoms are those symptoms that most people don't have. Most people don't have. Not everybody, I'll come to that, most people don't have. And the two most common are first of all hallucinations. A hallucination is when you perceive something that is not real. So you hear a voice and there's nobody there. You see something when there's nobody there. So you have a perception, and it's largely about voices, but not always. There can be seeing things as well. There's a perception when there's no stimulus, is the definition. And most people don't have that. The second positive symptom that most people don't have are delusions. A delusion is a false, fixed and unshakable belief that isn't true. And so the most common, the simplest delusion is that I could believe that I was being, I had a transmitter inserted into my brain from a Martian, and that was transmitting information out. And so most people would think that wasn't true. And if I really believed it, that would be a delusion. But it becomes a bit more tricky when you actually think, well, what about if I thought I was being followed by MI5 and they were tracking me? Now that could be true, and as a doctor then you have to make a judgment, is it true or is it not true? And I had a patient who thought he was being followed by the police. I didn't think he was, but he'd come in from Zimbabwe, into the country from Zimbabwe, and I was never entirely sure that there wasn't some political processes being involved in, and that you could have believed that he was being followed by the police, and certainly he'd got all sorts of things he was being followed, he thought, by the people in the Zimbabwean embassy, and that I found that there was, and so they used to make a judgment, well, how real is that, and how do you do it, because both those things could be true, unlike the man from Mars. You then start having to say, well, what's your evidence? Why are you saying that? And depending whether you say, well, I've seen people writing things down, or you think, well, that might be true. The apartment is being bugged. That might be true, but is less likely. What becomes even less likely is that people read significance into untoward things. So people drop their keys when they're passing, and that's a signal. And you think, oh, that doesn't sound likely to be a signal to another operative, and that's likely to be delusional. So hallucinations, these false perceptions, delusions, false beliefs, and then the third one there, which actually comes to us, is people have disorganised thoughts. Well, lots of us have disorganised thoughts from time to time. But people with schizophrenia, sometimes we find it very difficult to plan from A to B to C, to organise their life so that actually they can actually just get up in the morning, get themselves dressed, get themselves out to an activity, things that you might, other people find reasonably straightforward, then they struggle with. And sometimes when they're talking, their flow of conversation, suddenly they're talking about something, that the Queen is having tea today. There's just a disjoint in actually what's and so that's just a sign that people's thoughts aren't right. So these are the positive symptoms of schizophrenia. Interestingly, although people don't usually have them, when you do studies in the general population and ask people whether they've ever experienced these sorts of you find that about 1 in 20 have. So although we talk about them as being not found in the normal population, when you actually there's a significant number of people who have slightly odd experiences, often when they're perhaps a bit tired, perhaps they're a bit stressed, alcoholic experience, so it's not completely unusual. The other group of symptoms are negative symptoms, and by negative, it's not that they're being difficult, and that's sometimes one of the problems with the negative symptoms, but they are symptoms that reflect people not doing things that they would otherwise normally do. People struggle with looking after themselves properly. They're poor self-care. They withdraw from social activities. They lack motivation. Even their emotions are lacking. They don't get either very upset or very cheerful. A sort of a blunting and a sort of closing in of how people are. And very interestingly, when you talk to relatives of patients with schizophrenia, it's these symptoms that are actually much more difficult to cope with, because people do cope with when their nearest and dearest have these delusions and hallucinations, because they recognise them as being ill. They think, oh God, the poor person is really, really troublesome if they're hearing a voice in their head all the time. But actually somebody doesn't want to get up in the morning. Well, is that illness or is that laziness? And so the difficulty that relatives of people with schizophrenia have is often related to the negative symptoms. And then the final set of symptoms are related to thoughts, that people, about the disorganised thoughts over the positive symptoms. People actually with schizophrenia can have problems with their memory, their ability to plan, and their ability to make decisions. And there's a clear link between schizophrenia and those thought problems. And so it would be reasonably clear, I think, that actually patients with schizophrenia actually cover quite a broad area. So there's all these symptoms. How do we bring them together as a doctor to make a diagnosis? It isn't completely straightforward.
Slide changes the title Diagnosis Schizophrenia. The speaker then discusses the points on the slide.
And if I just explain what this is, what a first rank symptom is, to make a diagnosis of schizophrenia, you need one type of symptom that is so odd that really nobody could have it. So my symptom of, because it's completely impossible, my symptom of the man in Mars having put a transmitter in my head while I was asleep, that is completely impossible. If I really believed that, that would be enough to make a diagnosis of schizophrenia. That's such an odd belief. There are some types of hallucinations that are so odd. Not that the ones that hallucinations of people talking to you are less common. So if I was in my head hearing, oh, Laurence, this is a dreadful talk, and everyone in the audience is bored, and they're looking bored, that isn't enough. But if I had a couple of people in my head both talking about me and saying, oh, he's a wicked person, and the other one said, yes, I think he should be punished. I said, what should we do to him? Let's throw water over him when he goes out of the building. That sort of that two-way conversation in your head is actually much more odd than the first example. The first example, you can actually understand, well, if you're anxious, you could start having those feelings, and actually the more anxious you are, well, when does a thought become actually a voice? And sometimes, so that isn't enough. So it's one very odd and impossible symptom, or two of that more broad group of symptoms that I've just talked about. And they have to be present, and it depends. Some people say these symptoms have to be present for only a month. Some people say it has to be for 6 months. And clearly more people will be diagnosed with schizophrenia if you say it's only for a month, or 6 months. And the symptoms have to be present most of the time. So just having fleeting odd thoughts isn't enough. They have to be there for most of the time. And then is there a test? Well, I haven't told you the answer to that. There isn't a test for schizophrenia, but it might be. When I started training, it might be that there will be one at some point in the future. When I started training as a psychiatrist, I was taught that actually that there was the brains of people with schizophrenia were no different from brains of people without schizophrenia. There must be something happening in there. That's now changed. Now, there are differences in people that have a schizophrenic illness to those that don't. In a couple of areas.
The slide shows images of 4 MRI scans.
These are head scans of two lots of patients who are identical twins. And a lot of the studies in schizophrenia have come from identical twins. Identical twins, you'd expect things to be identical. They're genetically identical. And so if there's a difference, that interesting. And what we have here is two identical female twins. This is the person who doesn't have schizophrenia, the twin who doesn't, and this is the twin who does. And what you can see even as the background, that the spaces in the brain here are bigger than the spaces in the brain there. And so there's quite a major sign that there's a difference between the brain of somebody who has schizophrenia and the brain who doesn't. And exactly the same is being shown with a man here. The spaces in the brain of the well twin are smaller than the spaces in the brain with the unwell twin.
Slide changes with the title Cellular Disarray in Hippocampus of Schizophrenic. There is a graphic that is discussed by the speaker.
Looking into slightly more detail. Now, you're not going to be able to see all of this, but actually, where in the brain is there a problem? The area of the brain which has a problem with schizophrenia is right in the middle of the brain, the areas that deal with our emotions, called the hippocampus. And this is your brain section. It's right there in the middle of the brain is the hippocampus. And all I really wanted to show you here is the difference. This is a patient who is well, and this is their nerves in the brain, in quite an ordered pattern. And actually, this one actually is the brain of a patient with schizophrenia, and a very disordered pattern of the cell. So what I'm actually saying is that there is a difference that we can see both on scans and that these are taken from patients who have died. When you actually look at the cell, there is a difference. But that doesn't mean that we're yet able to actually have any test. We can't do that blood sugar test that you have with diabetes, but there is something happening in the brain that we can see on a physical level of the difference with patients who have schizophrenia.
Slide changes with the text Schizophrenia is rare.
Right. How common do you think schizophrenia is? How common is it?
1 in 100?
1 in 100. Oh, there we are. That's the answer. It's 1 in 100. And I would be surprised if many of you didn't know somebody that had actually got schizophrenia. And I just completely outside. There was someone I was at school with. I went to school in Bournemouth in the 6th form. Totally well, and then went to university and had a breakdown, and he had schizophrenia. And that's just somebody that was in my class at school, and in the 6th form at Bournemouth School, there would be about 150 people in each year, so you'd expect at least one. And then when I went to university, there were only 6 of us at the college I was at, and actually one of them actually had a breakdown and developed schizophrenia. So this is something that you're very likely to come across the knowledge of someone that has schizophrenia. And the great difficulty people with schizophrenia is that then because of the social withdrawal, because of the stigma, they then sort of lose contact with the friends that they would have had normally, and it becomes much more difficult. So don't then see what happens to these individuals. But it isn't that rare, and in fact, for example, it's more common than diabetes. More common insulin-dependent diabetes.
Slide changes with the title Epidemiology. The points are discussed.
Men and women are equal, and I'm going to show you something about that. And the main age when it starts is young men is more common in the early years, but 15 to 45. It's an illness that particularly becomes apparent in early adult life, particularly for men. For women, it comes later, and there might be something slightly different about women who get schizophrenia later. But it's very much that when people are just starting the onset of their adult life. And actually, when you look at the prognosis, that's how well people do with schizophrenia. The later you get it, the better, because if you get it early, it can have such a difficult effect on your ability of making relationships, of studying, of getting a job. It causes more of a problem for individuals who get schizophrenia early than those who get it late. Interestingly, the risk is similar in different countries. It's no different in India, Nigeria, Africa to Western European countries. Although the impact is different in different countries, because clearly the healthcare systems are very different. But when you if you look at it's about the same. Unlike, for example, eating disorders, which are much more common in Western European, Western countries.
Slight
And
changes
this
of
is
the
just
title
a slide just to
hospitalisations
show
for
the
schizophrenia in general
individuals,
hospitals per 100,000
when
by age
people
group
are
from 1999
admitted
to
to
2000.
hospital.
The data is
To
discussed.
crude scientists, we don't admit everybody. This is the ages. So this starts at 15 to 19, and then in 5-year blocks. And the purple graph is for men. And as you can see, men are much more common in the early years. That's when more men are being admitted. And then women become it becomes more common later on. And so there's this issue, which is interesting, never really resolved, as to why men are more likely to get schizophrenia early and women are more likely to get it later. So what are the causes of schizophrenia?
Slide reads, causes, genetic, environmental, drug use.
There is a genetic cause, without any doubt. And again, when I started training, it was very exciting. They started finding genes for schizophrenia. Found genes for schizophrenia, very exciting. And could you then treat it? In fact, they found lots of genes for schizophrenia now. And actually, what we know is that there isn't just one single gene. It's lots of genes.
Slide shows a graphic with the title Rates of Schizophrenia among relatives of schizophrenic patients. The data is discussed.
But actually, if you look at your chance of getting schizophrenia, it very much depends on how closely you are related to somebody. If you have an identical, so this is the general population, which is about 1%. So if you take 1%, if you're an identical twin, your identical twin has schizophrenia, it's about 50%. But that's interesting, isn't it? Because it means that although your risk of developing schizophrenia is hugely increased, so it's increased by 50 times, it's still not 100%, because these are identical twins, so why are they 100%? Why isn't it 100%? So it's clearly, although genes are important, genes aren't the only thing. There is something, the genes must give you a vulnerability to developing schizophrenia, but they don't mean necessarily that you will develop it. And the rest of it really just depends how close you are. So if you have one parent who has schizophrenia, it's about 7 or 8%. A parent who has children with schizophrenia, it's increased to about 12%. Brothers and sisters with schizophrenia are about the same as twins who aren't identical. But it is interesting as to why identical twins is still only about 50%. So there are other factors. What might those be?
Slide shows a graphic with the title Odds Ratio. The odds are discussed.
Now, all you have to know about this slide is that if you have an odds ratio of 1, it means that there's no difference. So anything that's odds ratio of 1 means there's no difference. So if all these are greater than 1, means that if you have, for example, you're born in the winter, you're more likely to develop schizophrenia than born in the summer. But the fact it's only just over 1 means that it's only just more likely. And why that's important is that there is something about developing infections. It's the mother. This is the mother developing an infection. There's something about the mother developing an infection pre-birth that increases the risk of schizophrenia, particularly with rubella, that's German measles. So, and that's why that's why there's slight increased risk in the winter, because that's when you're more likely to develop infections. So there's something about infections in the mother. There is something about problems, other problems around the birth. It's interesting, bereavement. Famine, major disasters clearly cause stress in the mother. There's something about the mother being stressed that increases your chance of developing schizophrenia in later life. And there's something about what happens in the birth, if there are problems with the birth. So there's the child is small, the mother develops an illness, the child has the cord around its neck and develops a lack of oxygen. all of those will increase the risk of schizophrenia in later life. They're all very small risks, because actually lots of mothers develop infections and the child doesn't develop schizophrenia. Lots of mothers are stressed at the time of birth, the child doesn't develop schizophrenia. But when you actually look at you have the genetics, and you have a whole series of other things that might influence the gene.
Slide shows a graph with the title Cannabis Consumption at the age of 18 and Later Risk of Schizophrenia. The data is discussed.
The one biggest thing that you can do to stop yourself from developing schizophrenia is not to take drugs. This is studies that come from Sweden. In Sweden, they still have national service, so all young people enter the army, and part of entering the army, they're all asked about how much cannabis they consume. And this is the number of reported use of cannabis in the previous month. And this is the cases of schizophrenia. And what this shows is low use, up to 4 times the previous month. Actually, there really wasn't much of an increase. But actually, as you start using more, there's a very significant increase. And there's a bit of cause and effect here. So, is it that those that are taking more cannabis were taking the cannabis because they were worried they'd already started developing these old symptoms, and therefore they were taking the cannabis as a way of self-medicating themselves? And it's difficult to completely disentangle it, but I think that the evidence is reasonably consistent now. But particularly if you are somebody who is going to be vulnerable to developing schizophrenia, taking the drug tips you over. So if we go back to our identical twins, our 2 identical twins, one has got schizophrenia and one hasn't. If the one that had taken the drugs, that actually might have been a factor that tipped them over into schizophrenia. If the one that didn't, even though they were vulnerable, they didn't have that stress that was actually happening in their life that tipped them over the edge into schizophrenia. And so I see lots of young people in my clinic actually who take drugs, and they do sometimes say to me, well, lots of people take drugs, and that's true. And most of them don't develop schizophrenia, otherwise the clinic would be completely full. But for some people, taking drugs, if they were vulnerable to developing schizophrenia or psychotic illness, they are just vulnerable, and the drugs in them actually has a much more devastating effect than the drugs in others. And cannabis use is one of them. But the other drugs, cannabis is the one that's most studied. Many of the other drugs, particularly amphetamine type drugs, would have the same sort of effect in actually causing schizophrenia.
Slide reads, schizophrenia is uncurable.
Is it incurable? Well, to some it is, and they need to be clear. That doesn't mean that people can't be helped and helped very significantly, but for some it isn't.
Slide shows a graphic with the title Outcome. The graphic is discussed.
And this is the outcome for patients with schizophrenia. There are four ways of thinking about the outcome. There are some people, and this is about 20%, so that's quite a high one actually, but it depends how you diagnose it, that have one episode of schizophrenia, and then they never get another one. And they think, well, did they really have schizophrenia? And there's all sorts of things. But actually, even when you be quite careful about how you diagnose it, there are a group of people that have one episode. It can be quite a severe episode. People could be admitted to hospital, and then remain completely well forevermore. The next group, which is actually a very big group, are those that have an episode, get well, but then actually have other episodes later in life. So that is about a third. This group that actually have episodes. Between the episodes, they are well. And people can be completely well, and that's really important to remember. You can be completely well with schizophrenia. I have patients in my clinic that are living with their families, being parents, holding down jobs, they take regular medication. I usually see them sometimes once a year. I don't really need to see them, but if they're on medication, I check how but actually they are leading completely normal lives. And then you think, oh, well, they really need the medication, and then you stop it, and then you find they have another episode of illness, and so you actually do just think, actually this person is well and is benefiting from treatment. And so these two groups, which is nearly about half, actually have quite a good outcome with their schizophrenia. So some don't have another, and some can be very well. There is another group that actually have an episode and they never completely get back to normal. And then they have another episode and they never completely get back to normal. So the two examples of the people that I knew with schizophrenia, they got ill in their late teens and they never got back to being able to do what they would have been hoping to do. So my colleague that was the medical student with me never actually got back. He tried to come back, but never actually got back to medical school. So that there is this problem, and the main problem is those thought problems, never quite getting the ability to memory problems, the ability to plan and retain information remains a problem, or positive symptoms remain a problem, or the negative symptoms remain a problem. And then there's a final group, which is another quite a significant, about a third, that actually really remain unwell whatever you do. And so they have their episodes getting worse and worse, and they don't get better. Not to say they can't lead satisfactory lives and do lots of things, but actually they remain unwell. And each episode they have, they get a bit more unwell. So the outcome is very variable, and what we don't know with schizophrenia yet, because as you might have gathered when I talked about how we make the diagnosis, are these different types of illness in many ways? And actually, if I was coming to see you in 20 years' time, would we be saying, well, this is one illness, this is another? And a bit like the sort of 18th century doctor that would have come and talked about fever. And say, well, this is how you treat fever. And fever clearly has lots of different outcomes, because we now know fever has lots of different causes. And actually, in some ways, still with schizophrenia, I think we're still looking at probably a group of disorders that clearly have things in common, but actually things that are different. And what we can't do easily is separate out at the beginning those that are different.
Slide reads, treatment is worse than the cure.
Now, this is a big issue, and that is this great worry that people have about the treatment. So you've got this disorder, and people have quite negative views about having a diagnosis of schizophrenia, but what about the treatment? And is the treatment worse than the cure? And we need to understand what treatment we
Slide
give.
content is read by speaker.
And the first thing with any treatment, and schizophrenia is absolutely no different, is you need to actually inform people. And educate them and explain what the diagnosis is. And giving a diagnosis, there's some controversy about giving a diagnosis. And so, do you want to, would any of us want to have a diagnosis of schizophrenia? And do we sort of talk around the subject, say you had a psychotic episode, or you've been visited by not being yourself? Actually, it's quite important if you give the diagnosis of schizophrenia to actually tell patients they've got schizophrenia. So let's tell patients and their relatives how are they going to get the information that they need? Because there's a huge amount of information out there in the days of the web. And actually, if you don't give people, don't give patients the diagnosis, that they are really being stopped from actually a lot of the information and help and support that they can get. So, just like many other personality disorders, another one, people head around actually giving the diagnosis of personality disorder. But actually, unless doctors were actually clear about a diagnosis and explain why we think that the diagnosis, and explain, well, that there are problems with it, and there's also positives as well. Patients are left in a bit of a limbo. So diagnosis is important. And again, that's no different from physical illness. When I was a medical student, we used to stand at the end of the beds of patients and talk about them, and we used to talk about them having mitotic lesions. And what we meant by mitotic lesion was that they had cancer, because the cells, there's something wrong. And we don't do that anymore, because actually if someone's got cancer, actually they need to know they've got cancer, and actually doctors talking in a code isn't helpful. And one thing also that we now do is actually when I write to a patient's GP, as I always do, actually the patient gets a copy of the letter, and in that letter it says what the diagnosis is, and that should never be. I have a couple of complaints from relatives who said they got this letter from the doctor and they had this diagnosis, and they were a surprise. It shouldn't be a surprise, because there should have been a discussion about it. So that education information is really important. Along the lines of what I was telling you now, but medication is really important for schizophrenia as well.
Slide content is read by speaker.
And there are different types of, they're called antipsychotic drugs, and they've been around since about the 1950s. The older antipsychotic drugs, and then around the last 15 years there have been newer ones, which initially everyone thought were better. They're not better, they're probably about the same in effectiveness, they have different side effects. Come to side effects in a moment. And then some people have their medication by injection, and some people have it by tablets. There's no difference in how beneficial it is, whether it's by injection or by tablet. But actually, if someone's not going to take their tablets and have the injection, you know that they've had the injection. And there's no difference about contraceptives. There's some women have contraception by an injection, and then they be taken. But actually, remembering to take the tablets, remembering to take your tablets every day, it's very difficult. It's actually difficult. I don't know how many of you have to take tablets every day. Probably women more than men, and that's why the male contraceptive pills never really taken off, because nobody trusts men to take a tablet every day. I have to take tablets for blood pressure. The tablets I take, I'm pleased to say, don't have any side effects at all. And when I take them, they bring my blood pressure right down to normal, and I forget all the time. I think they're a good thing. My children are just horrified at take them because they have a stroke, and I just forget. So I forget to take a tablet that I absolutely know I should be taking. It doesn't cause any side effects, and it works, and I forget to take it. So it's absolutely no wonder that our patients don't remember to take their tablets for anything. But actually, the tablets for schizophrenia, although they do work fully, and they do have side effects. And so actually we need to work with our patients to think, well, how are we going to help them take tablets? What tablets they can take, and they see the benefit of. And sometimes patients have depo, and sometimes patients choose to have a depo.
Slide reads fears of medication with 5 reasons. These are discussed by the speaker.
Why don't they take their medication? And there's all sorts of reasons. It was that I went to a talk, a wonderful talk by somebody called Kay Redfield Jameson. And if you ever want to read a book, it's not about schizophrenia, it's about bipolar disorder. If you want to read a book about what it's like to have bipolar disorder, it's called The Unquiet Mind. The Unquiet Mind by Kay Redfield Jameson. And Professor Jameson is an incredible speaker, and she's written an incredible book. And because it's what she has is bipolar disorder, and she is a professor of bipolar disorder at Johns Hopkins University in the United States, one of the top universities. She's a leading American academic in bipolar disorder, and she talks about her own bipolar disorder. And she particularly talks about taking medication, and the medication she was taking was lithium. And lithium has side effects. She absolutely knows about the benefits of lithium, and I've heard her speak, and we put out slides that show lithium stops people killing themselves, it stops people having as many breakdowns, it's not perfect, it has some side effects, but actually has huge benefit. And she describes in the book, and she describes when she talks, she gives talks about sitting with her psychiatrist. And remember, she's a psychiatrist, and the psychiatrist is talking to her about taking lithium, and she's saying, why is he talking about it? I'm not going to take it, I can't bear the side effects. But she wasn't brave enough. She wasn't brave enough to tell the psychiatrist she wasn't, so she just nodded and said yes. And so we absolutely, that there is this worry that people have, and she's sort of addicted, but she thought she was having side effects. And the other thing is, she was talking about when she had relationships, she would have to hide the tablets, because if the tablets were in the medicine cabinet and somebody saw them, would they think she was mad, and how embarrassing it would be? And so there is this stigma, so when you're on lithium, what's that for? And the other problem with the medication for schizophrenia is that actually they're taking it for a long time, and so it's not you take your antibiotics and you get better after 5 days. We're actually talking about medication you're going to take for months and months, if not years and years, and who of us want to do that? And so there's this real there's a continuing battle of the patients have in their minds, and really working with our patients is what's the benefits and what's the side effects, and weighing up all the time as to where that balance is, and that has to be eventually an individual decision that the patients make.
Slide title, How do antipsychotics work? There are 4 points that are read out by the speaker.
How do they work? How do these drugs work? And I put that slide up because actually how we learned about how they work is through amphetamines. If you take amphetamines, if you take speed, you will develop schizophrenia-like symptoms. you will develop delusions, or people feel persecuted, you will hear voices. The symptoms you get when you take amphetamines can be very, very, very similar to schizophrenia. And what amphetamines do is they release one of the chemicals in the brain, dopamine, and it's the release of dopamine that causes the symptoms. And the drugs that we use block the effects of the dopamine. And all the drugs that are effective for schizophrenia all block the use of dopamine. And so there's some suggestion that in schizophrenia there's this naturally occurring increased dopamine release, and that's what the drugs act to prevent. And the side effects are also linked, because although you stop the psychotic symptoms by blocking the effect of dopamine, if you block the effect of dopamine, you also cause Parkinsonism. Because Parkinsonism, which is when you have the sort of shake and a shuffle, is caused by too little dopamine in the brain, and so the treatment for Parkinsonism is to give people drugs that cause increased release of dopamine. So you can see how dopamine has effects. One part of the brain, too much dopamine causes psychotic symptoms. Another part of the brain, too little dopamine, causes these movement problems that you get. And getting that balance right is one of the problems that you have with all of the antipsychotic drugs.
Slide shows a complicated diagram of a nerve that is discussed by the speaker.
And this is just a rather complicated diagram. So this is a nerve which has dopamine. Dopamine chemically is released from the nerve into what we call the synapse. And what the drugs do is they block what's called the receptors. They block the receptors here, so the dopamine can still be released. It doesn't have any effect on the next nerve there, because all these receptors are blocked. So that's how all the drugs work, and that's the cause of both how they work, and it's the cause of their
Side title: The effects C of antipsychotic drugs. The points are discussed by the speaker.
Well, they're actually reasonably effective, but not perfectly effective. So about 2/3 respond, so there's still some that don't. They remain on medication. If they've responded, about 2/3 will remain well. If you didn't take the medication, about 2/3 would relapse. So what that tells you is that the medication works, but not for everybody. And if you don't take the medication, you increase the chance that you'll relapse, but actually you might relapse anyway, because some will relapse anyway, and some won't relapse whether or not they were taking their medication. And if you go back to remember my first slide, although there are those people that didn't relapse anyway, they just remained well, and so there's always a bit of suck it and see with patients. So when I've now been a consultant here in Poole for 17 years, so actually there's some patients I've now known for 17 years. You know those that for whom medication is working, and you say, look, we've stopped your medication twice now. Each time you've got unwell within 3 months, so let's keep going. There's others that actually doesn't seem to make any difference one way or the other. So you say, well, let's stop it, and what we then need to do is make sure that we pick up your symptoms really early if you relapse. So medication isn't the whole answer, but it actually it's a helpful part of treatment.
Slide reads side effects.
And these are the side effects. I've talked a bit about movement side effects. A real problem with almost all the medications, people put on weight. And none of us want to put on weight, and so that's an issue. There's no easy answer to it. Some of the medication causes people to be tired and sedated, and there's problems with causing diabetes and reduced fertility. But the biggest issue, probably for most people, because you can deal with sedation, is weight gain and movement side effects, and that's why people stop. And you have to balance up: would you rather not have your voices? Or would you rather be a stone and a half heavier? And those are difficult decisions that people have to make, and they aren't easy decisions.
Slide title: Psychological treatment. Points are discussed. So,
but drugs aren't the only treatment. There are also psychological treatments. And I'm going to talk about those for a bit, explain what they are.
Title: Psychological treatment. Points are discussed.
They also share a common purpose. And actually, to be absolutely clear, this isn't either-or medication. Actually, talking treatments can be hand-in-hand with medication. They both go together. So it's not, well, shall I take the drugs or shall I have the talking treatment? Actually, best treatment is both. For most people, it's both. And part of what talking treatment is to work together in a sense of collaboration, that the doctors and nurses and other therapists and peer workers, you're working together. You have the same ends, you have the same ends. Physical activity is important. Actually making sure that people continue to do social activities, they think about work and other skills, and it all has a sense that actually a bit about a positive attitude to the future, a sense of hope, and actually the recovery movement, hope is really important. To get a diagnosis of schizophrenia, let's get a diagnosis of many other difficult, actually to get a diagnosis of multiple sclerosis, to get a diagnosis of diabetes, to get a diagnosis of epilepsy. So all difficult diagnoses to have. In none of those conditions I've given you are there cures. We can't say we'll get you better. But none of them are mean that this is a hopeless life sentence. There are lots of things that can still be done. And actually that's what with schizophrenia, we actually have to work with actually helping our patients understand that even with schizophrenia, although none of us would want it, it's a short straw, that there's still many positive things that people can be doing to actually make sure they lead the lives they want to be leading.
Slide read by speaker.
We'll just talk about CBTs, cognitive behaviour therapy. These are just three broad principles, and it's going to be a very little description of one symptom. But one thing is to not see the psychotic symptoms of just being absolute sign of madness and being ill. That there's a continuum of normality and illness. And again, I gave you that example of voices in your head saying, oh, you're giving a crap talk. That is on that continuum between being well and being ill. And it's not all or nothing, and that can help in CBT. To accept CBT, you don't have to believe in schizophrenia or the different causes, or you can, what's important is actually what symptoms are you having, and how can we help you with the symptoms, and what difficulties are you having. Some people hear voices, and actually they don't mind us at all. They describe their voices as comforting. There's somebody in quiet moments chatting away, saying nice things or inconsequential things, it's just part of who they are. Others have people actually chatting away, saying actually horrible, denigrating things that are just painful to hear. One thing that I did, that's actually very interesting, is you can put headphones on that actually just are like hearing voices, and how enormously distracting it is to actually having this chatter going on when you're actually trying to think or trying to speak. So it depends what your symptoms mean to you, and that's an important bit about CBT.
Slide shows a graphic of a pathway. The journey and points are discussed by the speaker.
And if I just give you this is a good example to use in a university, particularly a university at the start of term. It's actually how somebody can develop a feeling of being got at. And so we start on this path that our students, in that typical age of schizophrenia, leaves home, goes to college, they go to college, it's actually stressful, they're going away from all their supports, their family and friends, they don't sleep properly, they might take drugs for the first time, and then they develop anxiety, they feel they're different, everyone else is having a lovely time, and they're having a horrid time, and there's something odd about them, why aren't they making friends easily? And so when they're feeling odd, you start looking at ways of confirming that. If I just give you an example, I'm sorry to keep talking about me talking, but I can look around the audience and I can actually say that there's somebody in the corner that's closed their eyes, because that's more confirmation that I'm boring, that I'm no good. There's somebody else on their iPads. Now it could be that they're tweeting great talk, or it could be actually they're answering their email. So you can see exactly how ordinary things actually, depending if you're feeling stressed and unconfident, start taking on a particular meaning. You're walking down, you're coming out of your flat, and your new flatmate that you've only known for 2 weeks doesn't say good morning, how are you, just ignores you. You think, oh, there's something about me. Don't think, well, he's never very good in the morning, he didn't say good morning to his parents for the last 2 years. You make more of things as they are. You then come, that gets you absolutely have a real sense that things are going wrong, that you're odd, that actually then people not only are misinterpreting normal events, but you start getting a sense of there's something very peculiar about me. If there's something peculiar about me, are there people then talking about me? Are they spreading rumours about me? Are people saying things so that nobody's going to like me? And people are spreading rumours about you, you then might feel threatened by that. And what this is, so a patient might come with this thing that they're being persecuted, they're being got at, they are seeing people talking about them, and you can then start taking it back and saying, well, let's try and understand this. Let's see if we can get some meaning out of this. And so that is a different approach. It's a cognitive approach to actually, okay, what I'll do is I'll give you some medication that actually might make the medication might well it's not either or. You have some medication, but also trying to get some understanding of how this type of symptom developed. With voices, there can be ways of, well, can we distinguish between the voices of people outside, friends and others, with the voices in your head? Is there a difference? How can you distract yourself from the voices? When are the voices worse? When are they better? Can we actually look at making sure we do more things when they're better and fewer things when they're worse? So that is how we have a talking approach to both hallucinations and delusions.
Slideshow graph that's discussed by the speaker.
Does it work? These are a whole series of studies of CBT, the positive symptoms, negative symptoms, depression, and total symptoms, and actually these are studies, and this shows that actually by and large patient symptoms improve with CBT. They particularly improve, I think that might be the next slide. No, it doesn't. They particularly improve when you give CBT and drugs. If you want to get your best improvement with symptoms, you give talking treatment and medication.
Slide reads family work, points are read out.
There's a real issue with families, because particularly with young men, they work with families, and what we know, there's something called expressed emotion, and this is work from about 30 years ago, of showing that patients with schizophrenia that came from families with high expressed emotion did badly. They got more symptoms, they had more relapses. Patients with families with no expressed emotion did well, with fewer symptoms. And what expressed emotion is, very simply, is the Mediterranean of people getting very excited and shouting and laughing and lots. That's expressed emotion. People that very much, parents and families that are very much in your face, compared with a sort of stiff upper lip, don't talk about anything, everything's under the carpet. The British stiff upper lip, everything under the carpet was better for patients with schizophrenia. And so if you had your family, and going back to my negative symptoms, who were screaming at their children, get up you lazy so-and-so, you're 18, and when I was 18 I was out of work and I'm not looking after you all day. I've been mother coming back screaming, the dishwasher hadn't been emptied and the son hadn't got washed and shaved, as opposed to those that accepted that this was part of an illness. And so what the treatment there is, both is family work, actually helping patients and the families understand that actually if you've got schizophrenia, actually toning down the emotion is likely to be helpful. But secondly, actually what also did, if you separated the parents and the children, not so they moved out, but actually took them out of the house, so actually if it's using people going to a day centre and going out for about 35 minutes a week, actually was a really helpful intervention. And that's normal, of course, because actually young people aren't spending all day with their families. They just aren't. And it drives my son has just gone to university this week, and so it's difficult when your children go to university. But in some ways, it's a bit of relief, because actually it's been quite difficult at times, and actually just home all the time doing nothing, it would be very stressful. So actually getting patients out of the house and doing things with other people is helpful. And again, family work and medication.
Slideshow's graph with the title Combining Medication and Family Education in Schizophrenia, Annual Relapse Rates. The graph is discussed.
And that shows that this is the people who relapse. So if you have any treatment, 70% of those relapsed. With just medication, 45% relapsed. with medication and family work, and so over a 6-month period, a 20% relapse. So actually, again, showing medication and these talking and psychological interventions are best.
Slide reads spotting early signs, points are discussed.
So there's things what people can do, and actually when I was opening that asked you, what can people do for themselves? And one is actually how do people and their families spot the early signs of schizophrenia. And these, sometimes before voices become absolutely clear, or delusions, that people start sleeping not so well, they start developing anxiety. But before you get to a clear persecutory delusion, before I feel that people are talking about me, people start feeling just an anxiety that they can't quite pinpoint. They just know something's not quite right, but don't quite know what it is. And that is an early sign. And sometimes you know what it is. I know that I'm being followed. I know I'm being talked about. But an early stage is a sense of it not being quite right. Personal hygiene at work are early signs. They could be early signs both of the development of schizophrenia in the first place, but also of a relapse.
Title: Avoid drugs and alcohol, points are
I've talked about
discussed.
drugs and alcohol. Very interesting. People take drugs and alcohol because it actually helps, they feel it helps, but it causes more problems in the long term. Patients with schizophrenia, about 60% have a drug problem as well, and nearly a third have an alcohol problem. So drugs and alcohol are very common in schizophrenia.
Managing voices, points are discussed.
I've talked a bit about how to manage voices. Being with other people is helpful because it's distracting. Listening to music through earphones is helpful. And actually how you distinguish the voices, that people describe that as helpful.
Smoking, points are discussed.
Smoking. Shocking. 40% of all tobacco smoked in the UK is smoked by people with severe mental illness. 40%. And in the States, half of all cigarettes are smoked by people with severe mental illness. Smoking is a real issue, and actually one of the part of the stigma I think that we've had in psychiatry is that people would go into hospital not smoking, would start smoking, and actually even with that nurses we're talking about our hospital smoke free, so we can't make smoke free because actually we're about patients that need to smoke. Well, there's actually more reason why patients with mental health problems need to smoke than patients with physical health problems need to smoke, and actually just as likely to die of their lung cancer they've got schizophrenia as if they haven't. And so the situation that actually all the public health work that's been done on smoking, we're now left with smoking is very much a disorder of severe mental illness. And we as professionals need to do much more in actually helping our patients stop smoking. Because to have nearly half of all the tobacco being smoked by people with severe mental illness is quite shocking.
Diet, exercise and stress, points are discussed.
I'm going to talk about physical health again in a moment, but actually diet and exercise and reducing stress is good for us and just as good for patients with schizophrenia. Actually, if our health is better, our mood is better, and we have a decreased risk of relapse. So there are practical things that can be done for all of us that are just as helpful as schizophrenia.
Slide reads schizophrenia only causes mental health problems.
The final thing I'm going to talk about before I get to the violence right at the end is, and clearly I don't think there's any causes mental health problems, patients with schizophrenia die, on average, 25 years earlier than patients without. 25 years earlier. And why is that? And it is almost not because of suicide. There is an increased risk of suicide in patients with schizophrenia, but almost all that premature death is due to physical health problems. And as I've just shown you the figures for smoking, it'd be no surprise that smoking is a real part of that. So smoking doesn't just cause lung cancer, it causes heart disease, strokes. Second issue of patients with schizophrenia is their diet, and that's why diet is important. They often have a poor diet. And we talked about obesity and poor diet linked with all the issues of getting diabetes, all the issues of being overweight. And so that's the second big killer of patients with schizophrenia. And then there's all the lifestyle issues of actually exercise and doing the things that actually keep us fit and well. Patients with schizophrenia are much less likely to do exercise. So it's in some ways that we now in in psychiatry is to be focusing just as much on our patients' physical health as their mental health, because their physical health that they're going to die from.
The slide shows a pie chart with the title Obesity in Patients with Schizophrenia. The data is discussed.
And that's just the figure of obesity in patients with schizophrenia. And as you can see, the normal weight is under 20%. And the obese is over 50%, but over three quarters are overweight.
The slide shows a graph with the title Prevalence Rates of Tobacco Use in Psychiatric Disorders.
Tobacco, and that's just interesting, use of tobacco is up in all conditions.
The data is discussed.
This is the use of tobacco from the States, but actually patients with schizophrenia, you've got 70% of patients with schizophrenia smoking. They're also smoking in other disorders, but the schizophrenia is the one.
Speaker reads slide content.
And why? I talked about their lifestyle, I talked about medication, but actually another issue is poor access to health. Patients with schizophrenia don't necessarily go to their GPs, and actually there's a real stigma issue with accessing healthcare. I was just talking to the junior doctors in St Anne's, talking about if somebody gets ill, they ring up the hospital to arrange for the patient to be admitted. And they say that their response is a sigh on the end of the phone, and then the description is in Paul, we need to get them back to St Anne's as quickly as possible. Well, it's outrageous if there's a sign on the end of the phone. Why should a patient from St Anne's be any different from a patient being admitted anywhere else? Clearly they need to come back to St Anne's when they're well, but actually not as soon as possible. It should be no different when you come back to St Anne's any more than anybody else. So actually even here today, the experience of patients with mental health is there's a groan from physical health services. They're seen as difficult and a sense that as soon as humanly possible they'll get back to a psychiatric hospital which clearly doesn't have the resources to look after physical health. And this was brought home to me in a very powerful way when I was a junior doctor in London. And I picked up that one of my patients, she was a 55-year-old lady, had pneumonia, baked-in pneumonia. She got a temperature, and when I listened to her chest, she got clear signs of pneumonia, and I arranged for her to be transferred to the medical ward for treatment. And she was, with the hospital I worked in, had patients, had psychiatric wards in the same hospital as the medical ward, so it actually wasn't that difficult. And then I went to see her the next day, and to my absolute horror, that she had no treatment started. She hadn't been given any antibiotics. She had just been moved from one ward to another, and I made a fuss, and she did start her treatment, but she died later that day of pneumonia, completely unnecessarily. And again, just a sense that because she had schizophrenia, that actually she was somehow less deserving of treatment. And quite a lot went on but that remained a real problem. So stigma, this issue about access to treatment remains an issue that then compounds the lifestyle and medication issues we agree.
Slide reads, people with schizophrenia are dangerous.
And then the final issue is how dangerous patients with schizophrenia are. And there's absolutely no doubt that all of us will read articles of absolute outrage of someone being killed or harmed by somebody with schizophrenia, and then there'll be a report saying, oh, this patient had poor care and services are dreadful, and that probably happens 2 or 3 times a year. So it's not helpful. The chances of a patient with schizophrenia being involved in a violent, the other way around. The chances of a patient with schizophrenia not being involved in a violent episode in the course of 1 year is 99.73%. So if you were worrying about the patient next door to you with schizophrenia, each year there would be less than 0.25% of that patient on average would be involved in violence. Not homicide, that's violence. So the vast majority of patients with individuals with schizophrenia aren't involved in it.
Speaker reads slide content.
However, there is so who is involved in violence? Why do we get so caught up in this? Well, this is the risk factors for violence. And so if we want to protect the public from violence, what we should be doing is looking up young men who've been drinking. And it's young men who've been drinking that are perpetrators of the vast majority of violence in the UK, without any doubt, the vast majority. Young men who've been drinking, who've been violent before, and and it is linked with low socio-economic status. Only if you can see the Ryan Club might sort of question that, but it's young men drinking that are violent. But there is an increased risk if you've got schizophrenia and you abuse substances, particularly schizophrenia and substance misuse. That does increase the risk compared to the general population. So we can't say that schizophrenia is at no increased risk of violence, but it's much less than other factors. And patients with schizophrenia are 14 times more likely to be a victim of violence than they are to be the perpetrator of violence. 14 times more likely. So actually it's really important that we put it into a context. So not denying that there can be a problem. And actually one of the roles that I have as a consultant psychiatrist is thinking, oh, is this individual going to be a risk to others? And what do I need to do? But also remembering they're much more likely to be at risk from others.
Slide shows a bar chart. This is discussed by the speaker.
And this is the issue of violence. If there is no violence, this is an American study, so there are slightly different figures. But if somebody hasn't got any mental illness, the prevalence of violence over a year was 7.3% of an individual. If you had schizophrenia, it doubled. If you had substance misuse, it was 5 times more likely. So patients using drugs or alcohol was 5 times more likely than the average. But actually, major mental disorder and substance misuse is a problem. And so when we see patients with schizophrenia, that's another reason to make sure we do our best to stop substance misuse being.
Speaker reads slide content.
And so, I suppose I've hoped that you now know a bit more than you do about what schizophrenia is. You know that it isn't rare. There are lots that can be done. Treatment has benefits as well as problems. There are real issues about physical health problems in schizophrenia, and that we can't ignore the issue about violence and schizophrenia, but that actually in the media is hugely good.
Slide reads, if you would like to find out more about the dignity, diversity and equality work at the university, please contact Dr. James Palfman K, Equality and Diversity Advisor. Email diversity@bournemouth.ac.uk, www.bournemouth.ac.uk/diversity. The Bournemouth University logo is then shown on screen.